Shall I introduce or you would like to start, Dr. Anush?
I'll start now. Okay, I'm Dr. Anuj Clark. I'm a consultant critical care at Sunshine Global Hospital, Surat. You are
is it a part of Global Hospital, Dr. Anush?
No, it is Sunshine Global Hospital is a chain of 3 hospitals in South Gujarat, and it's not part of global chain. So I'm working in intensive care as I'm head of the intensive care department here, and I'm working in intense critical care since last 22 years. And since 2017, we are working on this project, and we labeled it as Arrest Outcome Consortium, where just like Rock Consortium of USA, we thought we will give name according to, so that it should remain anonymous and should not be confused with any other. So this is a first online CPR registry portal that we have created. It is nothing but, it is not only a portal, it is a software attached to it, which gives us the real-time CPR data analysis. And I'm going to tell you in short about the same. So why we need to create, why we created Arrest Outcome Consortium. How come CPR scenario is different in India as compared to West? India needs their own guideline. So we have had a guideline designed in 2011, then again in 2017. We need data. There is no need to discuss about that. And studies till date, I'm going to highlight very shortly in a one table, and then going to tell you about the limitations in that database. And then we need, then we'll tell you about some practical difficulties that we faced in data compilation and analysis, which was standardized documentation, and then why we need registry. We'll tell you a couple of slides, and then our journey from CPCR cell to AOC, we will tell you in short. And then in short, last, we will show you the video how this registry works. So why CPR scenario is different in our country as compared to Western world is obviously we'll start with very basic stuff, like we have more males on the road as compared to females. So our OHCA data would be far different in the in our country as compared to Western world. Still, the number of people traveling by two-wheeler is much more than four-wheeler as contrary to the Western world. CPR literacy in the lay people is still in infancy at its best. And I'm very happy to say that now we have Indian Resuscitation Council. Council is trying its own bits to promote, take this CPR torch to lay people. And there is at least a national database of how many non-medicos are trained, and that's the way it starts. Every country, no, Rome was not built in a day. Every country progresses like this. So Anesthesiology Society has done a very good job in creating IRC under their own society, and then IRC is taking on bits and then trying to standardize the process. It will take its own time, but we are proud to have that. At least we have a council of our own now, and we make a concrete steps. And I'm sure that Dr. Mohan will agree that he must have consulted n number of CPR sessions for medicos and non-medicos, and everybody has their own records that how many individuals trained. We have also trained around 281 BLS workshops done till date, and I'm doing it since 2000. So around 20 years, we have been trying our best to, till now we have a record of around 8,000 people trained in basic lab support. So still, we still have a good Samaritan law passed way back in 2016 by Supreme Court. It's not, it's not law, it's actually a ruling passed towards against a petition filed by Save Life Foundation, and after which police are expected to not to harass the lay people. Guidelines are laid down, but still how many people in India know about it? And hardly 2 or 3 states have adopted this Good Samaritan law. And I think Karnataka is one of the first one. And many other states are in the process of implementing it. But still people afraid of doing CPR. And so that's how our India is different. Bystander CPR is non-existent to our best. In our own database, say in Caro study published in 2017 had reported 1.3% bystander CPR rate. And our study that I presented in this National Congress, we have as high as around 14% bystander CPR rate in our OHCA. But these all things are very small anecdotal reports, because the standardized format is still missing. But good things that now we have our IRC. Now we have doctors, because of NABH, it is mandated that all the hospital staff has to be trained in standardized format. Data management has improved. Pre-hospital care is improved after introduction of 108 in most of the states, although few states have they differ in that. IHCS CPR is improved because of NABH pressure, JCI documentation issues, and that's why gradually the things are falling in place. So these are goods and bads which we differ. But for having an audit cycle, say, what is the level of documentation? I would like to quote this one study published in IJCCM in 2017, that if you look at all the components of CPR, how many are documented properly in the existing form in that particular Indian teaching hospital, the almost only 2.5% were perfect. That means most of the almost 98% of forms were incomplete in some or other way. This is the ground reality as late as 2017, and that improved only up to 15% of total completeness of the forms in CPR. So this is the ground reality. It's like I always say that I believe in a Hawthorne effect. That means if you participate in a study, you will have to fill up the form. While if your forms are incomplete, you can't upload the data online. So you have to emphasize your subordinates to complete the form, and for that the pressure percolates down. So that's how we improved over 8 years of this institute. That once we started standardizing our format, then started making online portal for uploading the portal, we faced the difficulties, and that's how our form completion rate today is nearing 90-95%. So just participating in a trial like this has led to improvement at ground zero, and that's what we all need, want as a clinician. So this is the ground reality, and this is what we have achieved. And time and again, we can see that Dr. MC Kapoor, everybody must be knowing that he has written a lot about need for cardiac arrest guidelines in India, assessing outcome in resuscitation training in hospital. In one of the article, I would like to read the last sentence. With such a certified workforce on rolls, hospitals should now collate data, analyze it, and thereafter contribute the data to a national CPR registry so that we can generate India specific outcome data. This is what we exactly want. And this is the sole focus of creating this registry, where even Indian guideline published in IJA 2017, the third sentence of the guideline categorically state the major challenge is what lack of national CPR data and publication in this form in our country. So ILCOR has multiple countries as its partners, and all these councils are partner of ILCOR. But Indian Resuscitation Council is just formed, and now we are still not, pardon my ignorance if I am not updated of last month or so, but Indian Resuscitation Council is yet to be part of Asian Resuscitation Council, and Indian Resuscitation Council is still not part of Indian ILCOR. So we have a long journey to travel to appear on international fora. And India having 17% of world's population and has negligible database of our own as far as cardiac arrest is concerned. So these all countries have their own, not one, have multiple resuscitation guidelines. Europe has their own Eureka guideline, which is spanned across cardiac arrest registry, which keep on publishing every now and then they fine tune, and by analyzing an improvement, say audit cycle, and the quality circle says that you can improve only what you can measure. So unless we document and measure, we will never know what to do more to improve our own outcome. So this is, I'm sorry for this busy slide, but not intending you to read. These are the 16 or 18 published, or last 2 or 3 are our own data, which are yet to be published, where we have tried to put everything together. So many heterogeneity is found in this. DNR, obviously dead patients, and are put in denominators. So many hospitals do not recognize, they don't allow their doctors to document DNR. So they end up in documenting cardiac arrest or CPR performance without actually CPR being done. That is a fallacious data. If you start adding those data, your outcome numbers will look very ugly, because you have not done CPR wholeheartedly, or what we call it 2-finger CPR. That means it is not done, but it is documented only. And I have seen few hospitals, and that's why I've been very choosy in selecting a patient institute for coming on board. Cardiac arrest in terminally ill patient, included, not included. No data from large hospitals. Till date, even our registry, we have all the private institutes have come on board, so that the data will be obviously skewed, because the socio-economics case mix will be different. We have non-uniform documentation in all this database. Some have included in their publication all whole hospital data excluding OT and cath lab. Some included only ICU. Some included only code blue data. Some included code blue plus metcall data. Some include, so denominator for all are different. So you cannot, if I intend to do a meta-analysis from these studies, most of where you can see that this no data you can see. So when I put all the data published in Indian literature on cardiac arrest, Indian studies published, they are far from complete. Arrest time inaccuracies, very few there is no documentation or no clear-cut explanation about how do you, in OHCA, how do you say that this is the time cardiac arrest happened? So the no flow time is by grossly wrong. So if you want to intend Western countries have come up with an idea of termination of resuscitation rules, which is very clear in Japan, very clear in few of the Asian countries, where they have analyzed their own data and they have come to a conclusion that if your no flow time exists is more than X minutes, then you can terminate cardiac arrest after trying for Y minutes. This is what, because all intensivists would agree with me that amount of time, effort, energy, material power, manpower used or wasted depends on what the outcome. But we end up in doing it excessively for the fear of litigation, or for our sixth sense that, oh, this, let me try my best to revive this individual. So we don't have, if there, and sometimes even doctor and the medical teams are bullied that no, because I'm a powerful person, continue CPR, and we have ended up doing CPR for close to 2 hours for almost nearly brought dead patient. So this needs to stop somewhere, and the only way this can stop is have our own guidelines should spell out something from our own data. But unless we have our own large-scale data, no astute clinician will ever write a word in the upcoming new guideline. So our new guideline, as I was told, that they are in the process of revising now, because already 5-year-old now. So where do we find it unless we have their own nomenclature? You can see, either are we talking of CPR data, are we talking of code blue data, IHCA, OHCA, IHCA non-ICU, IHCA ICU, ED data of code attended by emergency team only. How do you account for those patients who are left against or discharged against medical advice. Do you consider them as dead or do you consider them as vegetative? These all questions are unanswered in most of the studies, and that we need to standardize before we actually collate our data, compile it, and before we do outcome analysis for Indian. And further, lack of monitoring of bystander CPR. First of all, bystander CPR is very less. Lack of standardization of BLS skills in healthcare worker. This, thanks to NABH, lot of standardization level has come in most of the healthcare providers, and that's why we initially started a norm that we will include only NABH and above tertiary care institutes data in AOC, so that at least we maintain at least that is a cutoff. Anything below NABH we will not go. And lack of standardized CPR practice and documentation. So for that, we have designed a CPR form, which we request all the partner institutes to adopt so that the data documentation is standardized. And we are still, as more and more institutes are joining, there is a lot of scope for improvement. We can further standardize it better. Gender bias in bystander CPR still unaccounted for. DNR not declared, resuscitation not done, issue discussed. Multiple cardiac arrests happened before that, especially in IHCA. So how many times you will fill up the form? One patient had 3 cardiac arrests and died after the 3rd one. Do you fill 3 forms? Do you consider 3 cardiac arrests? That is, Houston guideline clearly says that if ROSC is achieved for more than 20 minutes, that event should be terminated. That means if patient arrest again after 20 minutes of ROSC, then there is a new, it should be considered a new arrest. Because unless we standardize it, the denominator will vary very widely, so that our outcome percentages will dramatically change until we standardize it. So how we have achieved that, if patient have hospital has NABH accreditation, then at least some level of CPR standardization is achieved. CPI competency in nurses and doctors will be achieved in that way. Performance of CPR as per standards, because NABH mandates audit, periodic meetings and improvements. So once you have NABH standard maintained, then we can at least guarantee that X amount of lower threshold is maintained. So non-uniform code blue documentation. For that, we have designed form A and form B, which I'm just showing you now. And that form, once it is adopted, by and large, the documentation becomes perfect, and then it facilitates entry into portal as well. And we expect that photo of side A should be uploaded so that nobody can fudge the data. We should not allow any falsified data to enter into registry, even though we may go slow, but it should create its own impetus that if this registry is maintained with that quality control, then only the outcome will be reliable, good enough to modify our Indian guidelines. And we don't need single central data, we need multicentric. That's why this registry will fulfill the requirement, because the data from say one cardiac institute will have a different type of data versus a cancer institute. A multi-speciality hospital will have a different database as compared to government hospital. So that government institute, teaching institute versus non-teaching will have different database. If there are 2 centers, I have met with one problem, one institute, 2 different ICUs are governed by 2 different intensivists. One wants to feed in the data and another institute don't, another intensivist do not want that data to be entered into AOC registry. So these are the problems we are facing, and we will find solution to that, and then we come up with the new problems, and that journey will continue. I'm not worried about that, but we have begun. No uniform endpoints. That means when to stop CPR, that is left to the rescuer's choice. So at this moment we have no, but outcome format we have defined that we have to mandatorily document outcome at discharge, outcome at hospitalization, and there that goes into registry, because these are the endpoints anyone would like to see: how many patients reached to hospital and how many left home alive. No limited targets for future like CPR competency percentage. survival rate, percentage ROSC rate. At this moment, we have no timed targets. So AOC can create some benchmark. Say if you have data of 10,000 or 20,000 cardiac arrest, and then we can have a benchmark that, okay, fine, this is what average tertiary care institute should achieve. If you are below it, then you can say, okay, what can I do? If I above it, then rest of the institute can learn from them. So that's the quality journey can start once the benchmark is or database is created in a large quantity. The database has to be large enough to nullify the small differences between the institute. No flow time and bystander we have already talked about. No uniformity of ACLS team standards. So that means whether your one team will cover the whole hospital, you have two teams covering the institutes. These all needs to be discussed because that outcome can vary. No standard for post ROSC care. This is one area we still need more emphasis in our Indian guideline. Although emphasis in the Western guideline is also suboptimum to some extent. And in Italy, they have a course only for post ROSC care. We have course for BCLS or BLS, CCLS or ACLS, but nobody discussed in detail about post ROSC care, which according to me, a very one area which is lacking in patient. Say these are the red zones where no data, and these are the green zones where they have only super selective selections of the data. So there is not a single row which is not having any of these problems. This is the heterogeneity in the Indian data at this moment. So unless we come out with it, this is our track record, 281 workshops and covering more than 11,000 individuals till date. So, and this is the latest edition of NABH, which requires to have a CPR policy, CPCR cell training, providing hands-on training. Then you have to have a code blue system. Then code blue system have a code blue registry, code blue committee will meet, and then feedback. Then provided you have this whole system, which most of the NABH accredited hospital now have, and then their data can be collated and the outcome should be measured in form of a cerebral performance category. That patient, how was the CPC category before arrest and how was after arrest. This is the ILCOR standard. So modified Ranson's classification or this, but the ILCOR favors CPC. So select one scoring system, stick to it. If we all take the same language, then it can be. And this is what I was addressing to our form side A, form side B. As you can see on form side A, there is only file number. There is no name of the patient or name of the doctor. So you have to upload only side A on the photo of side A on the registry portal. Side B is for your local use. That means it is two sides of the same page so that your paperwork doesn't increase. The CPR file number will be generated the moment you upload this data on the registry. It is coded number so that data is de-identified at source. Then you can write down the name of the patient on side B and you keep this side B plus A in your local CPR register. That means this system will maintain clear-cut database in your own hospital registry, but at the same time, what goes into the registry are the essential points, and this manner we prevented duplication of paperwork, which is a very important problem at ground zero. This is the registry portal, www.aocregistry.com, and we have created this photo was taken long back. Today we have reached up to 1715 cardiac arrest data is already there, uploaded by our partner institutes, and those institutes are uploading data after COVID. During COVID, we had little bit of laxity. This online portal, and I will play a short video how we enter it so that we can have a glimpse of what is there behind this.
Hi, welcome all. Here I'm showing to you how to fill AOC registry form side A. First, go on the website aocregistry.com, then log in with your registered ID and password which was given to you. Once you log in, on the left side, you'll get a dashboard menu followed by AOC registry menu. Here on AOC menu, you will get the form site A submenu selected and you will get the form. Here CA means cardiac arrest and the file number is auto-generated. Please write this file number on your hard copy for the patient identification. Then enter the date, age and gender of the patient. If the CPR is not done, then tick here and it will ask you for the reason of the resuscitation not done. Select it and submit the form. If then which type of arrest it was, is it OHCA or IHCA, select it and then further select the location, arrest location, CPR location, witnessed or not, CPR and AED. IHCA, arrest and CPR location is the same.
And at the end of the whole database entry, you can download an Excel sheet which runs over 180 columns. And that Excel sheet is already there. You can download for any time period. You have choice of downloading the data only for IHCA, only for OHCA, or whole for any time frame you decide. So that whenever you want to do study by yourself, your database is already compiled and it's just a click of a button away. So that this becomes, say for example, we have database of 1700 today. So I have 1700 rows multiplied by 180 columns. See the amount of data you have created, and then you can start doing that subgroup analysis and then come out with the standardized formats. Say these are few photographs of the ready to download graphs, which comes out as a ready and downloadable form. That means you'd select the date range, you'd select the location of arrest, whether OHCA, IHCA. It will immediately calculate, the software will give you the graph, and then graph you can download for your presentations. So whenever you want to, say once you are on the board, you develop, you enter your data on day-to-day basis. The data should be uploaded only after patient's outcome is finalized. That means patient dies or after discharge. And that this registry also prompts you for, say your patient is discharged 10 months ago. So after 6 months, the registry will prompt you that this patient was discharged alive, and now 6 months elapsed, it's time to follow up. So you can find out this, you open up the page, you can open up your file from the registry and your own hospital MRD number. From that you can track patient's phone number and you can call them and take follow-up, and then enter the CPC category at 6 months and 12 months accordingly. So this has inbuilt 6 and 12 month follow-up, so that you can actually check what happened to this patient after going home. So this these different graphs I'm just running through very fast, because this all graphs we have created from Excel sheets time and again. But what is the beauty of it? That the type of data you want to select, subgroup you want to select, and it will calculate on a piece of on only a few clicks for your data, the date range that you have selected, so that it will choose the data from that range and immediately give you an output in this format. So this is the outcome format, where how many patients survived and how many remain conscious at hospital discharge, how many remain comatose at hospital discharge. This is the ultimate outcome we want to see. So this all format, and this is, as you can see here, this is the outcome data only from OHCA, from same date range. This is the database for IHCA, and this is the database for all locations. So whatever you want to put this three together, you want to put this together according to the date range, you can mix and match, and the way you want to compare your own hospital's performance before and after study. So this type of studies will become a piece of cake the moment your data is entered into a system like this, so that we can expect large number of publications from this database the moment it exceeds a threshold value for any difference to become statistically significant. And for that, you need large number. My hospital will add 150 data per year. Your hospital will add 150 data per year. But individually, our data will never reach to a statistical significance level. It may take 5 years or 10 years data to reach to that numbers. So unless we put all the thing into one basket, we will never be able to study, even though the India is having a large population. But unless we become smart enough, we will never be able to reach there. So this analyze not only location wise, even first rhythm wise outcome can also be different. So beyond that, we can have similar, now we have introduced similar graphs. More than 110 such graphs are available. Whatever you need, it is downloadable. So AOC has taken into account, once we standardize the structure of a CPR policy, structure of your ACLS team, training standards, supervision, monitoring, then you add up, then you have clarity about DNR, ensure all the data. That means once you join the registry, from that date, you decide a date from which all the data needs to be added prospectively. Say if you have this data from 2 years or 3 years, and you think that all the data which are required to fill in the registry, fine, more than welcome. You can join the registry retrospectively, in retrospect. That means we have had a large hospital in our one of the cities who said that we have data from last 3 years, very well maintained, and I would love to enter it. So they have entered the data. 600 cardiac arrest data was entered in 3 months. And this is what I would say, that we should catch up with it. And that can really help us as long as the database is complete. So at this moment, denominator needs to be interpreted very, very wisely, because this can be still a skewed database, because there is tendency to document only what the successful stories. If patient dies, then they may tend not to fill up the form. So we should refrain from such centers. We should refrain from such practices. 6 and 12-month follow-up, I have already emphasized. Data from irregular past participant. So we have kept a clause that if we observe a particular center of initially after joining data, after joining registry for few months, they enter the data regularly. And we observe that after a couple of months, they have stopped entering, and that will vitiate your whole denominator. So we have an option of hiding that particular center's data from the registry, so that the whole outcome indices can be, that is, I would call it data refining before we publish it at a large scale. So these provisions are already there. As we face the difficulties, yesterday only we faced the difficulty of uploading the data only on JPG format. So we accepted PDF format also that can be uploaded. So these all things, it's a journey rather than a destination. So at least what I would like to conclude here is that if you have created something, definitely more intelligent people coming on board will criticize it. We are open for it. And I would really like to read this quote, that if you are not criticized, you may not have done much. So so please join, criticize, make it better for, in general, to do a facilitate cardiac arrest research in India. And then we can actually put forward that research base for the guideline writers, that please use this guide as a platform based on which we can customize or modify our Indian guidelines for Indian setup. Thank you. Any questions on registry we can take up now?
Sir, it's very well explained, and I think I know about this data. Our colleague Dr. Manjula approached you once and tried to register, and for some reasons we could not do it. It's really interesting and encouraging. I'm sure that the Indian data is going to be very useful in the future generations for next people, how to really improve, because our cases are much more in number compared to the other countries as data wise.
So I have sent you the protocol prerequisites and
Yeah, this if you send it to this group now, because these people, all the people are different hospitals, so it may be useful for everybody. Or once I'll give you your contact number, your email it to all these people, so they will contact you, they'll approach you, or they'll take the things forward.
yeah.
So,
I'm just telling openly that at this moment, as I know Dr. Mohan Maharaj, it's like when we know that commitment, when we committed that I would enter this data, because say if we enter for a couple of months and then don't do it afterwards, then it will vitiate the, it will not solve the purpose. That means if I want to say that my registry has 40% male and rest are female, but this whole one sentence will become wrong if my data is selective. It is if I have to, we have to ensure that when I join a registry, from the date of joining till the current date, all the cardiac arrest should be entered. If you have any difficulty, I have had certain institute who said that my data entry operator has left. Now, in 2 months, that post is not filled up. What do I do? So we have helped them by sending our guy there, but that's a short distance we can manage. Sometimes we can say, okay, fine, you do it 2 months, 3 months data together. But these problems, as we come across, we have to keep on finding solutions. Anybody has any questions about it? Those who are interested in joining, please visit www.aocregistry.com. There is a tab in it. If you are joining, just send us an email on aocregistry@gmail. It is already, the portal itself has a provision for it. We will receive that, and then we will start the, we will send you the prerequisites for joining AOC registry, and then we'll take it from there. We need more people to come on board, but we need committed people to come on board, so that at least when we join it, we will join it for a cause. We have very clear cause that we want to show to the Western world that yes, we can. It's not to show, it's like we are clinicians. We need definite answers. If I want my guideline writers to tell me when to stop CPR in India, I said that, what is the limit of futility? You tell me. Yes, from if I have 15, 20,000, 80,000 cardiac arrest data, we will be able to answer that question. And I'm sure it is not a difficult task. If our 5 hospital can reach 1700 mark in 1 or 2 years, then if you have 20 hospitals, we can reach to 20,000 mark within a year. So that stage is open. At this moment, somebody might have questions about who is funding it. At this moment, we are funding from our own pocket. So what is the, at this moment, can we have an incentives paid something for feeding the data? The answer is no at this moment. If we have provisions for sponsors in future, then definitely at this moment, neither IRC, I'm actually talking with certain associations, but it's like you deserve before you desire, right? So let's reach to a threshold value before we put forward to societies like this to back us up. And the talks are on. So I'm hoping that we will succeed the moment we at least cross a threshold. So anyway, we are very near to become the largest. If we publish this 1700 data, then it will become one of the largest paper from India. So we are about to send in an international journal now. And I'm sure that this is just the beginning.
anybody else? Dr. Mohan Rao, Rani, Naveen, Shyam. Many people have joined. Any questions, anything regarding this?
Hello.
Yes.
Oh, hi. This is Dr. Rani from Vizag Care Hospital. I just have a question. So in the updated, uploaded data, we don't give any details of patient to you, right? Yeah.
No, patient's name, doctor's name, institute's name will not appear in the database.
Yeah. So in the outcomes, Like, did you say 6 months and 9-month follow-up we do?
Yes.
So do we upload that later?
Yes. Say once you are on board, you will have your credentials, ID and password. So you will have access to your data only. I will have access to my data only, my hospitals only. So that you will upload your section of your portal will remind you that you have 6 patients, say, or 10 patients have already discharged alive and completed 6 months. It's time to follow. So when you click on that button, it will tell you which patients have completed 6 months. So you call up those patients, fill up, and the moment you fill up, it will take up and will start displaying on particular bar chart that this is 6-month patient. Out of, say, you have last year you have 24 patient discharged alive, 20 patients follow-up is pending, 10 X number of follow-up is done, they are alive or they are dead. So that graph will keep on changing the moment you do follow-up and upload. So that this has inbuilt reminders in it. And we will see only the final version of it. That means if somebody wants to see the complete data, the whole registry, we will have periodic meetings so that we can complete data can be presented either once or twice in a year. So that everybody has a chance. If anybody wants to do research on particular subset of data, say for example, you decide to do a research. Currently, we are working on admission lactate and outcome. Some people want to work on admission temperature and outcome. Somebody wants to look at the anion gap and outcome. Somebody wants to look at the admission bicarb and outcome. There are papers in which admission potassium and by outcome is compared, and they said that but higher the potassium, poorer the outcome. So there are n number of possibilities, and as we go along, we will have a core group who will want to be very keen on advanced research in CPR. For them, we are in the process of making very detailed, I would say, version 2 of AOC Form A, where you can have all this finer details of admission temperature, admission core temperature, etc., etc. So we are in the process of that. So that means to be very frank, we are in the process of making a second version of the software now. Third version to be precise. This is already second one.
Okay, thank you. But the problem is we follow up till the discharge, and probably we call them for review, checkup and follow-ups. But usually, like, not many people are followed up till 6 months, 9 months.
This is telephonic follow-up.
They may go to their own primary consultants for the follow-up. So
fine, we can do telephonic follow-up, and telephonic follow-up requires only 4 questions. How is that person? Has he become independent in daily activities of daily living, etc.? So it are hardly 2 or 3 line conversation required for telephonic follow-up. If you can do it, fine. Otherwise, that remains incomplete in your database. So more the things incomplete, the compliance level will be low from that particular institute. And that is what we need to say. The whole intention of this registry is to have a standardized format and then try to bring our own standard to that format. Then again, elevate the standards and then again try to reach it. And I have pursued that in our own practice. This has really elevated the standard of CPR. Not only performance, documentation and management has understood that this guy is doing some serious business. So when I say that, okay, fine, this is something missing in our mock drills have become more regular, because this whole database, it makes sense. It is just journey. The moment you come on this journey, our own standards will improve. Even your hospital would love you to follow up that, okay, fine, you do telephonic follow-up. It just reminds them, okay, oh, this doctor has worked very hard and that's why I'm surviving. They might come for follow-up again. So This is a win-win situation. So more we be in touch with the patients on the long term. Some people do not prefer to pick up the phone. Fine, that's fine. There will be 10% loss to follow-up rate in our database also. Fine, we can't do much about it.
Okay, thank you.
So should we go on to the second lecture?
Hi, Anish.
Yeah.
He is Dr. Mohan Rao.
Hi.
He was in Visakhapatnam several years for 20 years. I think you were shorter time.
Yes.
Rahul Pandit, you joined, I think. No?
Sorry?
After Rahul Pandit, you joined in Samuels in Mumbai.
I joined before him. Yes, me, Dr. Rahul Pandit and Dr. Dilip Karnad, we were together in department. In fact, at that time, we must have interacted a couple of times in the beginning days, in the introduction of 7 Hills.
So very nice, and let us go for the errors talk.
Sure. Okay, let's move on to second topic.
Thank you.
Okay, yeah, my slides visible?
No, not it. So old slides are visible.
Okay, I'll close them.
I think all of us are different hospitals, so I thought it will be useful for our errors. This one, or you are conducting workshops, no? That we can split and do this.
Yes.
Yeah, it's visible.
Okay, so this is I have mainly 3 areas of interest. One is cardiac arrest, and we design AOC registry. Second is the error prevention in medical practice, and this is one area where me and my colleague, my friend Dr. Ritesh Shah is working from. We joined hands in 2013, and from there we started working on this project, that how can we spot errors in our own medical practice, and can we have a system which reminds us that error is about to happen, and we can prevent it. And since this we are working in this project, we have become more observant about own behavior, own method of talking to nurses, method of talking to method of documentation, the way we give command to our team, the way we tell that, okay, fine, remove the Foley catheter in evening. No, that's an ambiguous statement. Remove the Foley catheter at 6 p.m. is the statement. It may be as simple as that. But this all small things we have tried to put together and then come out with something called an error prevention module. We have already conducted around 10 workshops for medicos, especially intensive care professionals, but all other professionals from other specialties have also attended. And since in this Criticare 2022 in Gandhinagar, we were given platform to conduct this as national level, and around 29 doctor paramedic intensivists have attended it. So why we need EPM? Why we need training in, I would call it errorology. We rarely pay attention to the errors that we commit. And this is one area I would equate it to sex education. Everybody needs education, everybody needs training, but nobody would like to discuss about it. That these are the areas where it is obviously confidential. Nobody would like to disclose their own errors. Then how is going to study it? How is going to improve it? And it is not me. When you enter an ICU as a clinician, you would look at the patient, you will look at the treatment and regime. We all are trained in doing it. But we should not forget an intensivist is also an ICU administrator. You have the control over many of the administrative stuff in ICU, or you are also a team leader. When you look in your ICU and the happenings in your ICU, as a administrator or from a team viewer's view. That means we are, for a moment, for half an hour, just change your goggle. Try to look at the what we do daily from a different perspective, not a clinician's perspective. We are clinician. We will remain a clinician, but we have one black hole remained in our area. The way we look at, we can spot, prevent. So do I need to tell you anything about it? These pictures, I have error gallery. If I start showing it, I'm sure it will take me more than a 24 hour to display it. Everybody has their own things. Many of you have stored such memories in your brain. Gosh, we could put it into a hard drive and show to the world that this is what happens. But we need to look at it. Unless we look at it, once we tell it that one thing is on the left is obviously wrong, but one thing on the right, can we say it is wrong? Yes, the way it is grows, this is not stitched. So after 5 minutes, it will become like this. So can we spot at this problem at this stage rather than letting this happen on the left side? So this is what we need to change ourselves. That spot the problem before it can evolve to a irreversible stage or it harms the patient. Do I need to tell you anything about it? This is the blister created by hot water bag. Who is at wrong? Nurse should be more careful. Patient should be more careful. Patient relative should be more careful. Or we need to change the system that you don't use hot water bag in the hospital for a obtunded patient at all. Change the system. Don't keep on changing the individuals. You will never succeed. And this is what we have observed time and again. In last 8 years, we have zero incidents of this thing in our hospital because from the inception, we have never permitted hot water bag in our hospital at all. One of the physician has had to visit a court because of this thing happened to a mother of a very big celebrity in hospital. From that day onwards, we change our system because this is the same system we are going to practice for years. We don't want this faulty system to harm not only us, to the hospital and to the patient as well. So nobody is benefiting from this bad or faulty system, but who is going to work for this faulty system? You and me have to work it. So if no hospital is going to, of course, in today's era, NABH and JCI standards, hospital will have their own do's and don'ts, and then they have their own ways of thinking about it. So it is not one person fails, it is the system which fails. And so what the Oxford definition of what is error? A state of condition being wrong in conduct or judgment. The failure of a planned action to be completed as it is intended, or that is error of execution, or the use of a wrong plan to achieve the aim. That is error of planning. So problem can be at the planning level or at the execution level. But the important problem is errors of omission and commission. Commission means doing a wrong act. Omission means is not doing a expected act. Error of commission, pneumothorax during central line is very easy to calculate, but not sending potassium after having a profuse diuresis with furosemide infusion and then letting the patient develop complications of hypokalemia is an error of omission, which is very difficult to measure, and that's why our measurements of error is very, very, very poor. And that reflects the deficiency in the system, and more we recognize it. So I would quote this couple of studies which are milestones in this era, in the arena of errorology. That's what, let me tell you, errorology. A look into the nature of human errors in intensive care. A beautiful study done in Jerusalem, Israel, where they have noted that almost 178 activities done per patient per day. I'm talking of 1995. In 1995, I'm sure these activities must have become at least 1.5 times from there, because more number of machines, more number of gadgets, more sicker the patients. In era of hospital, we have now patient with a air mattress, with calf compressor, with IABP, with ECMO machine, with ventilator, with syringe pump, with multi-para monitor. So n number of things are connected, and that is making care more and more complicated. So what was there, 1.7 errors per day per patient in 1995 must have at least doubled by now if we actually measure it. This patient guys have measured it, and that's why they actually cut out with a number. So this number is become very popular, and it is already quoted in IOM's paper. We know that the name to err is human. This is coined by Institute of Medicine USA in 1999, and they have taken this number, that 1.7 error per patient per day in ICU, and ICU patients are have severe and potentially detrimental error occurred average twice in a day. So at least twice in a day this happens. So error should not be considered as an incurable disease, but rather as a preventable phenomena. This is what the conclusion in 1995. In 2005, they have a critical care safety study. Again, a landmark paper according to me. There in Boston, 1 year observation study where 2 physicians are appointed in a tertiary care institute in ICU for a year. I repeat my words, for a year, to observe which type of errors happen more commonly. And this is what they found, that most they have 45, whatever error found, the 45% were preventable and 13% were fatal. Most serious medication error occurring during ordering or execution of treatment. So less in planning, more in executing. And still we don't think that maintaining silence during handover is essential in ICU. So are we paying enough attention the way we practice? Because we don't analyze where the mistakes are coming from. So it is said that performance level failures were more commonly slips and lapses rather than rule-based or knowledge-based mistakes. It's not that people don't know about that the furosemide will lead to more potassium loss and we need to supplement it. People are aware, they do it. But are they doing it proactively or on time? That will prevent an error of omission. This is what matters. So failure to carry out an intended treatment correctly was a leading category concluded in this critical care safety study. But it is never taught in medical schools. We never discuss about errors. And does it harm only patients as it is shown in this? No, it harms the medical professional a lot. In this survey-based study done in France, they said that feeling of guilt amongst the healthcare providers in almost more than half, and shame in 42% of people. It associated with anxiety states and rumination amongst the healthcare providers. Fear for the patient, loss of confidence, inability to verbalize error, questioning oneself as a professional, at a professional level. That means they start questioning their own integrity. Am I fit enough person to treat such or look after such seriously ill patient? Anger towards the team and the patient, and even that anger comes home at times. So error and its consequences leads to professional burnout. And this not only happens acutely, it remains fixed in their memory for years and decades in almost 80% of people. 72%, it improved their vigilance and their quality of care because of their perception of error. But few professionals actually left the field because of error, and they consider and they stopped accepting. I have had one of the friend who has left intensive care field after such a big incidents happened in his ICU. So whose loss it is? Is it society's loss, hospital's loss for the healthcare professional? And why it is happening? Because we as astute clinicians have not looked into our own system the way we practice for so many years, and so it demotivates staff, demoralize them, it leads to allegations and litigious environment, and that ends up in staff burnout, and that creates a very, very unhealthy atmosphere at the workplace. You would not feel like going back to work next day morning. This is what it leads to healthcare professional. And meta-analysis are done whether it had something to do with depression. Depressed physicians are 1.9 times more likely to cause medical error, and medical errors leads to depression 1.6 times more likely, depressive symptoms and symptoms. So it harms, it leads to, it becomes a cause of depression, and that is, so it harms patient, we know, it harms clinicians and professionals, we know. Does it harm the hospital? Yes, in a big way. You can see this cuttings from newspaper, and I don't need to read more. Instead of doing digital subsection angiography for diagnosing and treatment of AV malformation in brain, instead of dye, a syringe of glue was handed over by a staff nurse to an intervention radiologist, and the whole hemisphere got infected because of that faulty injection, and that has led to 24 million pound was awarded as medical negligence to that girl, and hospital literally had to it is impossible for them to cope up with that much amount of fine, and that end up in shutdown of the hospital with that one incidence. So as you've seen, patients suing the hospital for hospital acquired infections, as in the Delhi Shalimar Bagh case, Max Hospital's license was cancelled because a newborn was labeled as dead and then had some movement in the limbs found by relatives, and then the whole ruckus started, whether it was a negligence in detecting death. One of our fellow colleagues hospital was sued that patient was brought dead, that CPR was not documented although done, and then taken to another hospital, and then they should show some ECG rhythm before actually was declared dead. So it was claimed that enough was not done in the first hospital, just because the documentation was not up to the mark. So medical error is a deadly disease. I repeat my words, medical error is as deadly as any disease, and it causes 2.5 million injuries in India every year. And we still have very, very incomplete data about it. And we never have and this is where we have been trying for 9 years, and it took us 9 years to reach a national platform to talk about errors at a national level, and we are happy with it. And Eric Moyen's paper, everybody interested in this, is a very excellent summary of the solutions, what you can do to minimize the error, whether you use medication standardization, computerized entry form, barcode technology, reconciliation. These are few things. I would say that this table is a Bible. If you can implement this, it can give you a long way. And those who have implemented, you can see that dramatic reduction in the error rates by different system. So this is a list. When they are implemented, see the amount of medical error reduction from 1.68 to 0.6, 190 to 62, 4 down to 1. So this have more and more benefit proven by implementing it. But has it been sustained for long term? The answer is no. This paper in NEJM published in 2010. The IOM paper published in year 1999. Since then, these all ways and means of reducing the error are published, practiced to a certain extent, but you can see all the lines practically horizontal. Very few you can see a downward trend. So over a period of 10 years, not much has changed in the incidence and prevalence of measurable errors. I repeat my words, measurable errors. And what happened? Number of people dying. An IOM paper published, which coined the air to air is human, is around 44 to 98,000 people in US hospitals are dying in every year because of medication error. That number has gone up to 400,000 patients dying because of Medicare error. And it has been shown that medication error has become the third leading cause of death in US hospitals. After ischemic heart disease and cancer, medication error, we have textbook of oncology and oncosurgeries. We have textbook of cardiology. But the third common cause of death in US hospital, do we have textbook on errorology? The answer is no. Why it's not there? we consider that it is not worth discussing. We are the system. Unless we discuss about the system, we will never improve the system. So we from to err is human, from Linda Cohn's title of this report, we extended is to err is human, accepted, but keep erring not. Why do we keep erring? Because we don't discuss it enough. Most common problem is in medication error. From medical errors or the errors, most common is in medication error. So if I say that I want to start somewhere, start from your medical chart, drug chart. This encompasses for more than 2/3 of the errors happening in the hospital. So that's the first beginning point you should. So it not only affects morbidity, mortality, medical professional and institutes, as we discussed. And what do we do with it? The conventional system, you document them. How do you document them? From retrospective chart review. You make a person sit in the medical records, either electronic record or otherwise, then go through the pages and look at the how many do we document our errors. Then how are you going to find it? So if the documentation is poor, you will find very less number of errors. So what do you study? Now prospective self-reporting by incident report forms. This is very encouraged. But in litigious environment where people making errors are fired, they are scolded in public, they are reprimanded, they are giving memos. If this thing happens, then most of us, we will not report errors. So incident report forms are not filed. So how are you going to get the data? And the audit cycle says that you can improve only what you can measure. But if you are not able to report it, how you are not going to document it, what is the pattern of errors in our system, how this system will progress. And to document it, I think we need, I would tell you the journey of ARF to AKI. Acute renal failure had more than 15 definitions. But the moment definition is standardized by either AKI network or KDIGO, then they said that this is how I'm going to define acute kidney injury, not renal failure. Renal failure is the last step in kidney injury. After the definition is standardized, the research has become standardized. And thereafter, the outcome preventive methodology has become standardized. So can we have the same path followed in errorology as well? Can we define our common errors? Can we work on our common errors? Can we have preventive? Let's say that error is a disease. Define it, study it, then find out that these are the preventive strategy and treating strategy or the mitigating strategy for each error. And I know it's a large field, but we have to start somewhere. This error evolves over a period of time. It is like a very small fire. So I'll give you an example that air condition was seeping water in corridor. Usually it doesn't find in nowadays in a hospital where all these systems are out. Say for example, just to give you an example, water on the floor in a hospital because of any reason. Staff slipped over it, complained, but nothing was done. Then a patient was being mobilized, fell and developed fracture, and then this patient sued the hospital. Now in fighting this case, cost around 100 times more than fixing up the primary problem itself. Maybe a leak from a pipe or somewhere, whatever it may be. But what in short, that if you stop it at early level, it prevents the harm caused. And that's why the error in evolution needs to be caught at a very early level. And the Henrich's principle, which is very prevalent in industry, especially in mechanical industries, they said that after 300 misses, you are going to find 29 minor injuries and 1 major injury after 29 minor injuries. So once this thing usually happens in the industry. What about in medical field? We don't know. Do you think this is an error in evolution? I don't need to tell you what's going to happen next when this patient will be shifted from one bed to another bed or bed to CT table and CT table back and back to bed. This line is going to come out accidentally. So if you spot at this level, can you intervene? Then this can be prevented. Is it an uncommon scene in ICU? Why we do allow 2-pin plugs in ICU? When we allow 2-pin plugs, the plugs will cost you 100 or 200 rupees. But what will happen if a syringe pump got defunct or discharged at the wrong time while patient is on the lift or a CT scan table or an MRI trip or inter-hospital trip or the interdepartmental trip? I don't need to tell you more. So can we fix up this 2-pin plug to 3-pin plugs? Yes, because this is how it starts. So I would remind us the Swiss cheese model by James Reason, that it is not incompetent or irresponsible clinician do not cause more adverse event. Is that the good people have bad days sometimes. So they say that models of quality improvement based on identifying or removing bad apple, clinicians have not been effective in improving safety and of healthcare, as all apple has bad holes sometimes in their life. So you don't say that I am very good, very careful, and tomorrow if you have just joined your duty after 20 days leave, and can you remain as perfect as before? No, your first day may be little lax. If you're not slept the previous day, your clinical acumen is going to go down. So it's not that bad people makes more mistakes. Good people on the bad days makes more mistakes. So this needs to be understood. So we can't keep on blaming doctors for the failure of the system. So all blame doctors, don't discuss how to prevent it. And there's a beautiful article written by Malki Ayer, and I encourage everybody to read it in Times of India. This is in 2016. You can search it from Google. And it said that existing solutions are not enough. Then let's think differently. Let's not think about who is wrong. Let's find out what is wrong. And this article written in Hindu, why blame doctors for the ills of the system? And very well said and explained in this article by Dr. Murthy, that let's have a rethought. Let's sit together, think about it, learn from the industries around us, as other industries have fixed up their problems. Like biggest example is automobile industry, and even bigger one is airline industry. They have standardized practices and they invest heavily in safety training and research. Is that money gone in vain? Answer is not. If you say stop one plane from crashing, it will amount to be a humongous amount of profit to the airline at the end of the year. So how much amount is spent? If we look at Indian or medical industry, if you look at the cost of human life, then this needs to be analyzed in that context. That do we need to spend enough hour in preventing errors? Then we need to think differently, because audit cycle, conventional cycle of study the incidents, look at the root cause analysis, then apply training, and then look at this has not worked. That means we need a different textbook of errorology. This is what I think. You can improve only what you can measure. How you're going to measure it? For active failures, you can do staff quality improvement. For latent condition in the system, you can do system perfection, as we have discussed just now. But what about situational errors? Situational factors means now you have in 10-bedded ICU, 2 beds are vacant, and suddenly 2 patients are transferred out and 3 are admitted. Now where you keep the 3rd one? Now this all major trauma incidents, 5 patients arrived together and system was unprepared. Now your very senior staff nurse is sick and not come on duty, and today is very heavy workload. These are situational factors. How are you going to cope with it? Do we have a strategy for it? Fatigue, drugs, alcohol use, stress, multiple activities happening together, everything affects healthcare professional. Do we have allocated anything for it? No, we don't discuss it anywhere. So if for a driver, you can find a signboard like this is accident prone zone, drive safely. Can I thought of accident error prone situation in your medical practice? Can I define it? Yes, we can. I repeat my words, yes, we can. Error syndrome is the way to go. So when we sense the error syndrome in evolution, we can get the effect like accident prone zone. That means I am in error prone situation. Be very careful. How many times I'll be more careful? No. It's not, you can't make men more careful every time. You need to design a system which can happen by, just give an example of Hawthorne effect. Hawthorne effect is an observer's bias. What is observer's bias? In this, Hawthorne is a glass manufacturing factory outside Chicago. They have conducted a survey, and that by increasing illumination, they have put observers in front of the workers, that whether increasing illumination in the factory can improve their outcome, improve their productivity. Their productivity improved dramatically. But later on that they realized that it is not because of the illumination. It is because of the observer's presence. People took shorter breaks. They were more efficient. They didn't chit chat while working. So their efficiency improved just because of observation. Because workers knew that they are being observed, their performance increased. Can it be put to practice in medical practice? Yes, they have done it. They fix up a camera in front of a wash basin. After 6-week period, initially, they have just observed silently without letting them know that this is working. The compliance rate was, hand hygiene compliance rate was only 10%. Then they introduce a beeper that if you are not washing your hand for enough time or enough time duration, it will give a beep and a light. With this real-time feedback, their hand hygiene, because they knew that I'm being observed, every person washes hand, every person washes hand up to the optimal method and the duration, their compliance increased to 80%, and it remained there for so long, as long as the system there. So can we have this type of system? Another very excellent experiment done in Women College Hospital, Ontario in 2014, where patients were given a feedback form at the time of admission, and clinicians and healthcare professionals were told that how many times your healthcare professional observed hand hygiene before and after touching you, you mark them. And the moment healthcare personnel realized that I'm being observed by my patient, because they're going to mark me for it, and that feedback form are taken. So 58% provider experience change in their behavior and health hygiene practices improved. 88% reported being more motivated to person hand hygiene, knowing their patients were observing them. So can beneficiary observe themselves? This needs more ethical discussion before it can be implemented at a larger scale. But these are thought-provoking ideas, at least. What we try to implement it in one of our 2 floors of hospital, where the 18 parameters of a drug chart were studied in before and after fashion. In before, these are the red charts where you can see they were suboptimal, lot of scope for improvement. And the after, involving the same doctor or the health medical officer who were writing drug chart, we involved them in study. That now let's sit together and we study the drug chart of your own floor. The moment he was involved in the trial, even before we could publish the trial, his own pattern of prescription improved. And these are the data. And this persisted, as you can see, from red it became blue, and from blue it became green. So lot of green, that tall it was already immediate effect were persisted almost for 4 months. And this we got award at the national conference in 2019 as well. So that means this Hawthorne effect works. We have proven it by it. And these 3 examples I have shown that Hawthorne effect works. So then how can we create, how can you use it to prevent errors? Let's coin syndromes. Syndrome is nothing but, Webster Dictionary defines a syndrome as a group of signs and symptoms that occur together and characterize a particular abnormality or condition. We observed peculiar constellation of circumstances. We call it, let's call it error prone zones which unfolds before actual error happens. Let me tell you one example that central line was not stitched properly in hurry. It was inserted in hurry after multiple punctures. Patient was very sick, immediately transferred to cath lab for plasty, and while transferring patient on cath lab table, this central line came out. Now, this is whole spectrum. Where the problem started, central line inserted in hurry. There the problem started. The doctor stitched without stitching it properly, applied adhesive tape. That is step 2. So can you see this error has started evolving? So now you are in the moment patient needs to be transferred to OT or cath lab or for a study in hurry. That is an error prone zone. So this error evolution started. So this has become an error in evolution. So if you put all this thing together and give it a name, let me explain you by an example that Midazolam hangover. We are all aware, all anesthesiologists, all intensivist physicians are aware that midazolam metabolite, hydroxymidazolam glucuronate, is an active metabolite which is excreted by kidney. In a renal dysfunction, this metabolite gets accumulated, leads to midazolam hangover that leave the patient drowsy with renal dysfunction. Patient with renal dysfunctions remain drowsy even after stopping midazolam infusion for days, and frequently they end up in tracheostomy. Now we know that, but gosh, somebody will remind us the moment create increases, the moment we find on first medication, on the first biochemistry report arrives in after ICU admission that this patient create clearance is low. This was actually put to study in Guy's and St. Thomas Hospital, London, and published as a paper in 2005 that slow to wake up patients, they have actually measured serum levels of 1-hydroxymidazolam glucuronate, and they have found that 13 out of 26 has detectable midazolam or 1-hydroxymidazolam glucuronate, and out of this 10 made a full neurological recovery. That means this is a fact, it happens, but can somebody remind us on time? Yes, this is a trick. We have labeled this as OMG syndrome. And OMG, as we know, that's a very popular Hindi movie, Oh My God. And Oh My God is a very hilarious movie. The moment you remind about it, those who have seen it will agree with me. It is all about God, and very hilarious movie. So from that, hydroxymidazolam glucuronate, short form is OMG. So this, the moment I said, be careful of OMG, that's what I need to tell to my staff. Now I don't need to even tell because they have heard me talking about OMG 10 number of times. So the moment my ICU practically minimize the use of midazolam and midazolam hangover in my ICU, I give you open invitation to please come and observe in our ICU. Midazolam hangover practically issue is gone, because this is Hawthorne effect created by coining the name and discussing in your day-to-day rounds. So we have 178 syndromes coined till date, classified them into different modules. So we have, now it's very clear. So error exists in our ICU. Do we all agree? Yes, we do. Great majority of them are preventable. Yes, studies have shown it. It harms patient, healthcare worker, and hospitals. We agree. Conventional method has not yielded result as we expect, and it is theoretical, difficult to practice. Common and recurrent error syndromes can be named, as we just give you an example of OMG syndrome. Once named, it can be studied. You can study the incidence or the prevalence of this thing in X or Y institute by an observer or an internal observer or a quality control manager. The moment you start talking to your team about it, you can very categorically pass a message that even you can spot it, because now I have feed this sort of a software in my brain that I have 176 defined syndromes. The incidence of that is very low because we could spot it. Not me, my colleague, my junior intensivists, my fellows, they can spot it very early in time, and that stops harming the patient, healthcare, and hospitals all. So hospital is also happy. Less number of medical legal suits, less number of quarrels, timely audio video counseling, timely proactive steps, timely reminders, timely reminder to other professional colleagues that this is a problem and this can happen, be careful about it, and then that can prevent it. So error prevention modules have appeared as a 6 to 8 hours training for healthcare professionals, and we have done pre-test post-test analysis by giving them case vignettes, and we could document 34% increment in error spotting rates in healthcare professional attending this type of structured training in error prevention. This is one of its first error prevention training for a healthcare professional ever designed as of I am aware. And if it is already designed more than that, I would be more than happy to go and attend it today. We are coming up with a book as well. So we have already 175 syndromes coined, and we have jotted down the criteria to define clear-cut definition of the syndromes. So in the module, we discussed that word by word. So we have 5 modules in that workshop: medication error, communication failures, prevent procedural errors, transportation of lacunae in transportation, and system errors. And at the end, we give a error gallery for them to spot the errors. And by pre-test and post-test, we give them results that this is your error spotting increment rate. So that becomes like a result of our own teaching, and that has consistently improving. But as we just discussed in AOC, the compliance rate, there are few people who finds it boring and it's like, okay, fine, I will come back and do not complete the workshop. For those people, we could not spot the error. So sorry, could not spot the error rate. So this is the way it goes. And this is the list of workshops we have done. Total 26 sessions, 10 workshops, 16 lectures in 5 cities, in 5 institutes. We have 5 publications on this concept and got 2 awards at national level, and 1 book is in process. So this is our journey from 2013 till April 2022, around 174. Even after copying and pasting this table, our number of syndromes has gone up further by 2. Every day we observe something, I concept something and keep on writing down. And this has helped us in changing the way we look at our own things. As we know that your eyes can see on you or your brain knows. So by training ourselves into spotting errors can really sort of changing or putting goggles in front of our eyes so that we can start spotting the error in evolution in our own practice. So this workshop is not all about I am good or bad. It's not we all are bad, we all are good. We all are having good intention. Nobody wants to make an error. When the error happens, we need to spot it in time. And I'll give you one very simple example. I requested one of my 2 staff nurses to spot errors, spot what is the problem on the board. You can see the one nurse who has attended the workshop, one nurse who had not attended the workshop. The first one said everything is fine. The second one says that this screw is missing, this board is about to fall, and then they got it fixed upon time. So this is how it makes difference. You train your eyes in spotting errors. Errors are everywhere. It may look as simple as that, but this screw is about to come out. If you don't fix it on time, this board will fall on somebody. So it's not question of preventing error only in the medical practice. It has helped me a lot in our own social life outside the hospital as well. It is basically a concept that is an error in evolution should be spotted on time. This is Dr. Kulkarni giving us award. This is Dr. Ritesh Shah with me. We both have designed it. And this is one poster we have published and we exemplified with this distraction syndrome, devotee syndrome, and post-tapping tussle syndrome. These 3 syndromes we have given example and designed the poster. and won the first prize in 2016. And this is what paper and medication error we have already told. So these are the 2 awards, and this is we are granted provisional patent by Intellectual Property Authority of India, and this is our patent already patent provisional patent number. So this process is on, and during this National Congress, this was the structure in which we have conducted this module. This is the first workshop in 2013 in Gujarat Criticon, where we initial name was do's and don'ts in critical care. Then we evolved it to change it to error prevention, and then since then this error prevention modules continues. So train your eyes in spotting errors. It really prevents harm to patient, yourself, and institute. Thank you very much.
Thank you very much, Dr. Anuj. It was very enlightening and very interesting, and very happy to know all these things. And I request Dr. Satish, Rani, Anuradha, who's seniors, and Manjula to talk.
Any comments? Say we have conducted this workshop for multiple institutes. Now we have started receiving invites from few institutes where they want to embody this concept of quality control in their institute. So we do go there, train their quality manager in syndrome recognition, and hand over a list of syndromes that this is what you can observe in day to day. And that list has kept on increasing, and that has inspired us to compile it in a book. So we will let you know the moment book is out. JP Brothers has already accepted to publish. Sorry?
Yeah, you already mentioned 176 syndromes are there.
Correct.
Thank
Any questions?
For your time, Dr. Anuj Clerk and Anuj Yam Clerk. So, and I think maybe we have a lot of seniors. There's a Dr. Satish from Secunderabad Apollo is also joined, and presently is Dr. Rani, Anuradha, and Manjula are there seniors, and they can contribute, they can ask.
So you have a group of doctors, or it is ISCCM in Visakhapatnam is hosting it? How are this all seniors are on one platform?
No, these are all, we are all friends. We just work as a professional group.
Fantastic. So that is very enlightening.
Rani, Satish, and Anuradha, Manjula, anything?
Hello.
Yes.
Oh, hi, Dr. Anuj. Very informative talk about errors and reporting errors. So the problem in any hospital or any institute is reporting the errors, thinking that they may get blamed or get punished. But people should understand it's for audit purpose and it's for constructive criticism, not for punishing anybody. So if the staff, doctors, if people know about it, then there will be more error reporting and more audits. And as every hospital does quality audits and departmental audits, then there'll be like a guidelines or policies regarding how to prevent those. So, but the starting problem is reporting the errors. So that should be encouraged actually. So that's what I feel.
Yeah, it's true, but it is more theoretical than practical, that this norm is always there, that people who report error should be awarded rather than punished. But the situation, the ground reality is different.
Good afternoon, Andy. Dr. Mohan sir and Dr. Anish.
Hi. Good afternoon.
Hi, I'm Dr. Satish.
Yeah.
So regarding this, is a beautiful class I've gone through. Now it is like eye opener for all the critical care specialists. Whatever you have mentioned is like a never-ending process. Quality is like very costly, and it is definitely to be implemented for the sake of a patient and well-being of good outcomes. But thing is now, what is that is error identification. So we implemented few like maneuvers, like whatever we say, like every floor there is a anonymous box will be there. Any sister can write the error what they have done without putting their name, and they have to drop it in the box.
Correct.
So that we can identify the error. And every weekend we used to consolidate all those things, whatever that is kept in those box. We are being like discussing on that, how to prevent that. So next step is once they got some confidence of doing all these things, then we started giving some incentives for identifying the best error.
Okay.
Like some programs like giving a good applause or some chocolate like thing or a pen like thing. Like we never used to punish them, and they got a confidence that if they report error also, they're in a safe hands. They don't get any blame of that. So that is one way we can encourage people to come out with their errors. That's how we implemented in Secunderabad Apollo, and it showed good success.
That's a very encouraging. In fact, many institutes do it, but most of this type of errors are error of commission. Error of omissions are very difficult to spot it.
Yeah. Thank you, Dr. Anuj, for your time and your efforts, and hope we are going to make use of it.
Thank you very much.
Thank you all for joining. Thank you, sir.
Thank you, Mohan sir.
Thank you. Bye.
Bye, Andy.